So while we're doing this, I'll say good morning. And I'm glad that everybody's sitting up front for the most part. Makes me feel like we have a little crowd so we can have a conversation. It would help me to know who in the audience is a pharmacist or a practitioner of pharmacy. A couple, okay. Majority of you, I'm going to guess, are then with pharmaceutical sciences, industry, those kinds of things? Yes? No? Medical, good. Okay, great. A physician? Okay. Hospital administration? Oh, excellent. Okay, good. Oh, good, good. So today, my talk is going to be more on the pharmacy practice side of the world and talking about primary care, which means physicians' offices in the United States, and having pharmacists work in physicians' offices as part of what we call a shared resource pharmacist network. So I'll talk a little bit about, in the U.S., what our medication use and safety facts are to kind of give us a basis. Talk about definitions for medication management because we all, even in the U.S., we're finding we're using the terms very differently. So I'll make sure we kind of talk about the definitions so we know what my perspective is on that. And then most of my time is going to talk about a project we had in Connecticut. It was a Medicaid, which is a state and federal program for patients in the United States who are lower income, and they usually have very complex diseases, so I'll talk about that, the study design, what our findings were, what some of the drivers were for success, and then close out with some patient perspectives, some people who were involved, as well as physicians who were involved. So this is, again, just U.S.-related data. We see that today we have a lot of medication use and safety challenges, dilemmas in primary care, in care transitions, and in readmissions. So primary care means primarily your physician's office, your primary care doctor, your generalist, sometimes they're called generalist physicians, okay? That's where most prescribing is done. About 75% of the prescribing of medications in the U.S. happens in the doctor's office. We have a lot of challenges with patients who have 4 or more medications, meaning usually prescription medications, because that's what we can track. We can't always track what they buy over the counter at home or herbal products or something like that. If you have 4 or more prescription medications, you're at increased risk for falls. We know that in our country, over $3.5 billion a year is spent on extra medical costs due to adverse drug events. Okay, so what we want to do is figure out how can we prevent a lot of these things from happening as opposed to pay for them later. Okay. Most of our cost of adverse events that happen in the ambulatory, outside of a hospital, those kinds of settings are really preventable. They usually relate to inappropriate prescribing or maybe dosing problems or too low or too high. They relate to drug interactions or medication side effects or errors or that sort of thing. And we also know that about 24% of prescription meds and about 76% of OTCs, over-the-counter drugs we can buy without a prescription, or herbals, are not listed in the doctor's electronic health records. So the doctors in the United States, depending on what electronic health system company you have for your records, some of them do a better job than others at giving you a place to report those or record those. But in a busy office visit for 10 minutes with a primary care doctor, many times there isn't much conversation around what else do you take except for the prescriptions that that doctor prescribed for you. Okay? Even we're finding that medications that a cardiologist or a nephrologist or some medical specialist don't necessarily find their way into the list of medications when you're at the primary care doctor. Their records are mostly around what they prescribed, if that makes sense. So that's primary care. Challenges in care transitions. By care transitions, we mean people think mostly of when you're in the hospital and you're discharged to go home, that's a care transition between settings. And there's a lot of things that happen around that discharge process that fall through the cracks. And so up to about 40% of the medication information is incorrect or is missing on a hospital discharge, okay? We have, this number is even more now, but probably 750,000 emergency department visits to a hospital emergency room, and about 120,000 hospitalizations are due each year to adverse drug events. So the more we can prevent these upstream at the prescribing point of prescribing, the better. And there are a lot of readmissions that happen because of adverse events, and we want to again, try to prevent as many as we can that are related to medications. So in the U.S., we define medication management as all the processes that are in place for all the patient's medications. So prescriptions, over-the-counter, meaning non-prescription, you don't need a prescription, herbal products, dietary supplements, vitamins, nutritional products that have an impact, okay? So very holistic. We want to look at all of them because they all can interact or have the potential to be harmful. It's all the processes in place to reconcile, optimize, coordinate, and monitor those medications to achieve evidence-based, cost-effective treatment goals for that patient. It's very patient-specific. And so these are the processes we use. I don't know if I have a little pointer here, but the lower circle there is the middle. Okay, yes, thank you. The lower circle here is about 2 years ago, we had about 11 national pharmacy organizations in the United States come together, and it took them a consensus process of well over a year to agree to what is a common process all pharmacists should be using, starting with collecting data. So collect data here, assess the data, create a plan for that patient, a patient-specific plan, implement that plan, and then follow up and monitor. So that's the process that we use. And that's called the patient care, pharmacist patient care process. I don't know how much I need to talk about this. I include it a lot of times when I'm talking to physicians in the U.S. because they don't understand what the training of a pharmacist is today. They may not have ever worked with a pharmacist in their training, or they did it in the hospital, but once they get out of the hospital, they don't interact with too many pharmacists. Even in the community today, you'll find that people fax information back and forth. They hardly talk. It's very rare that a physician and a pharmacist today talk. So I will, I don't know how it is in other countries, but I hope it's better than we have here. But you can see our training here is a Doctor of Pharmacy degree. Since 2000 is the entry-level degree. It's 6 years. Some are going now to 7 years. It has at least 4 years of clinical training starting out. So it's high school, 2 years of college, and then apply to pharmacy school. Pharmacy school is at least 4 years, if not 5. And those 4 years, you are in the first year of pharmacy school, you're going out and going into pharmacies, community pharmacy or hospital pharmacy, working with patients in a supervised way. You're not doing your intensive clinical training, but you start it. We also have residencies, post-PharmD residencies and fellowships. We have 9 board-certified specialties. These are boards that you would sit for as an exam after a few years of practice that you could sit for and become a specialist in all those areas. The 2 that relate more to primary care are ambulatory care, some geriatrics, and also pharmacotherapy is kind of our term for internal medicine kind of topics, adult medicine. If you don't have any of those advanced fellowships or degree board certifications, there are many certificate programs where you can go from a continuing education standpoint as a pharmacist and become certified through a training program that's both didactic and some experiential, and like smoking cessation or immunizations or things like that. So there's other ways that you can get advanced practitioner credentials. And on the right-hand side, in the standards that we have in our education, the expertise we have would be listed there: pharmacology, therapeutics, pharmacokinetics, dynamics, toxicities, drug information, medication safety. You can see that whole list, outcomes. That's what our curriculum requires today. Oh, so let me go back up. So I always say that our competencies, the pharmacist competencies today, are synergistic. They're not duplicative with any other healthcare professional. They really are. We try to do as much team-based training as we can. It's just the workplace doesn't always support it. We try to teach everyone that. But pharmacists, I think it's safe to say, in the United States, have the most in-depth training in therapeutics, pharmacoeconomics around the cost effectiveness of drugs, and the pharmaceutical systems, the complexities of how drugs get from manufacturer to wholesaler to pharmacist and patient and insurance and those sort of things. So we are probably more aware of that than some physicians when they go to prescribe a drug. They may not understand the cost barriers, and then they wonder why the patient isn't getting any better. They may not have even been able to afford it. So this is our project. It was in 2009 to 10. And it included, again, this is Medicaid patients. So these are adults. They had to have at least one chronic disease. They had to have 3 or more chronic medications for those diseases. And they had to be patients who were eligible at the time in the Medicaid system. And Medicaid then would have been the payer or the insurance plan at that point. We did not include non-English or non-Spanish speaking patients because we just didn't have any pharmacists who could communicate with them. And our sites were primary care providers. So we had 5 different primary care provider offices. And we wanted to make sure the offices also had electronic health records for greater than 12 months, because we didn't want to get into the situation of an office starting or putting in a new electronic health system. That's usually chaotic, and so we wanted to make sure it was well implemented and they had it up and running, and that would not present a problem. All the sites were in Connecticut. So we looked at medications. The first thing we looked at was medication discrepancies, meaning we looked at what did the medications say in the electronic medical record at the doctor's office. That's what they prescribed. What did the Medicaid claims say? That's what the patient actually picked up at the pharmacy, and there was a billing to the Medicaid program. And what did the patient tell us they were really doing at home? So we had 3 ways: prescribed, filled the prescription, and what patient was doing at home. And we wanted to look for what were the discrepancies or differences. Then for drug therapy problems, this list of 7, I think it is, drug therapy problems, this is part of a very well-validated taxonomy of drug therapy problems that's been around since about 1990 or so. The work of Linda Strand and Doug Hepler, if anybody's interested in that. So we classified the drug therapy problems according to that taxonomy. And then we were lucky to have claims data, cost data from the Medicaid program to examine the cost of drugs and of medical, labs, hospitalizations, ED visits, so total healthcare costs for the 12 months before the pharmacist was involved with the patient's care, and then 12 months after that first visit with the pharmacist. So the patient served as their own control here. And this is just a diagram of how we did this. We had the patient and the pharmacist met in the doctor's office. Now, why did we do that? That's unusual. It's new for us. It's a new model of care, but we want to test the new model of care for 2 reasons. 1, the pharmacist could only get access at that time to the electronic health record if they were in the doctor's office. In a community pharmacy, the community pharmacist does not have access to the doctor's health record, okay? So that gave us access to the electronic health record. And the second point is we really wanted to model this whole idea of a team, a pharmacist being an integrated member of the healthcare team, to the other health professionals as well as the patient. So we met the patient in their doctor's office, had a separate appointment with them. They weren't there to see the doctor that day. They were asked to come in because they were eligible for this program where the pharmacist was going to see them to talk specifically about their medications. That average visit, the first one, to go through all of this medication history and whatever, sometimes lasted 45 minutes to an hour. A physician, even if they wanted to, would never have that much time, okay? We looked at EHR, the RX claims, prescription claims, and what the patient told us. We looked at these two things. We're measuring discrepancies and problems. We created a medication list and an action plan that went to the patient. So that is written for the patient. The action plan would have things like questions they might ask their doctor the next time they see them, or something they could adjust at home. If we saw that they should be separating two medications, taking medications by an hour or 2 hours, but they told us they weren't doing it, we put that on their action plan of things they can do at home on their own. We also then sent what we call medication therapy management, or MTM, summary report of our visit with a note to their primary care physician so that they would document. And this note went into the electronic health record. Doctor read it, and then it was put in the electronic health record. It was put in the record the same place where all the other medical specialists would be. So the cardiologist note, if they had a referral, or endocrinologist or something, the pharmacist was positioned as the medication specialist, and their note went into that specialist note section of the chart. And then the pharmacist would do a lot of coordination with the patient, family members, or caregivers. If there were other doctors involved, we would communicate with the other doctors, like if we had a medication recommendation about a cardiology drug that the cardiologist was managing, we'd work with the specialist. If there was a home nurse coming to the patient's home, we would make sure that person, usually a she, was getting that recommendation list. And then the dispensing pharmacist, if there were any changes in or questions about medications that were being dispensed at the pharmacy. For instance, we found sometimes that medications were in the EHR, the doctor's health record, they were actually discontinued, but they still had refills, and so they were still dispensing and getting that, but the patient was confused about, should I take it? I thought my doctor said no, but when we talk about adherence all the time. I got my refills for this month, and it's there, and I thought I stopped it. So we might sometimes have to talk to the dispensing pharmacist. And this is what we found. So these were a very complex group of patients. They had somewhere between 9 and 10 medical conditions, chronic conditions. They were taking between 15 and 16 chronic medications a day. We thought maybe that, because we were so thorough about getting herbals and nutrients, and we thought that was going to add up. No, only one of these was due to non-prescription over-the-counter things at home. Most of them were chronic medications they were getting by prescription from doctors. This was not a study of just looking at diabetes or high blood pressure or whatever. We took patients who had any kind of chronic disease, because that's really what we see. We didn't want this to be constricted to like a trial or a clinical trial or a disease trial. We wanted to look at what patients are like every day that come into the doctor's office. This is what we found: pain, GI problems, lipid problems, high blood pressure, asthma, respiratory, diabetes, depression. Those were the most frequently seen diseases, and usually in combination, not just one. They were usually in their 50s, so these were not elderly patients at all, and they were primarily female. We had 88 patients enroll in the study. Just to let you know, we had over 3,000 names of people we called to be in the study. But because these people are supported with state funds, a lot of them were a little leery of, well, if I do this, will it affect my other health care benefits? Will I get cut off or something? We lost a lot of people because they were just unsure. But we were able to find 88 patients. We had 410 patient visits. The protocol was to allow us to see a patient monthly up to 6 months. So we could really intensely work with them for 6 months and see what difference it made. We had about 20 providers, mostly physicians, but a couple APRNs, and at 5 different locations in the state. So for these 88 patients who were now in the study, we first looked, remember, at discrepancies. We said any inconsistency in the dose, the drug, the dose, the frequency, the route, the quantity, or medication use between what the patient does at home, their EHR, and their claims. Okay? We found 3,248 in 88 patients. Not good. right? You would think we'd all be on the same page. We're not. The biggest discrepancies were 50% were discontinued meds. Discontinued meds by the prescriber. The only way in the United States that a patient knows that something's discontinued is the doctor says on the way out, oh, by the way, I don't want you to take this drug anymore. That's it. And if the patient is confused, doesn't understand, the patient is not thinking about stopping. There's no paper, there's no electronic signal, alert, reminders. It's just that, oh, by the way, stop this, okay? Or the patient. The patient would stop it because they had side effects, they didn't think they needed it, they couldn't afford it, whatever, couldn't get transportation to the pharmacy. They stopped it, but they never told their physician they stopped it. There's a good study that was done here, about 85% of elderly patients do not tell the physician when they stop doing something in their treatment because they don't want to disappoint the physician. But the doctor still thinks they're taking it, right? And that's a problem. So most of it was discontinued meds. We did find what we thought. We didn't expect to see this very high. We thought what would be this, a drug is missing, like they're taking an over-the-counter drug and it's not recorded in the doctor's list, in the medical chart. Or they're taking a med from a cardiologist that they tell us at home, or we see the bottle, but we just don't find it in the primary care doctor's chart. That's what we expected, but really it was discontinued meds was a bigger problem. So that's discrepancies. Then we looked at these, remember that taxonomy I told you about of these categories of drug therapy problems? We classified all of them, and this is kind of a summary. But we had relatively, per encounter, per visit, we could find about 2, a little over 2, medication-related problems in our study. And this is very consistent. Other people in the United States who do similar work to what we do, in Iowa and Minnesota, they find very similar things, 2 to 3, somewhere between 2 and 3 problems per patient visit that a pharmacist will detect and work on. Most of them had to do with prescribing. They either needed additional therapy or drugs were not needed based on evidence-based guidelines. So just to let you know, pharmacists aren't just making this up on their own judgment. They're doing this according to evidence-based guidelines and looking how that applies to the patient. Dose too low is more common than dose too high in most of our work. And you can see this is the percentage. Safety, adverse drug events was second. And then adherence, you can see if we put those two together, patient didn't understand the instructions, or patient prefers not to take or really forgets sometimes, okay? Because these were Medicaid patients, they usually didn't have to pay for the cost of the drug, so affordability of the drug was not an issue here because of the Medicaid patient population. The state was subsidizing or paying for all of their meds. In our state, they don't even pay a copay. Some states they do. And this we published, if you're interested in more of this, we published this in Health Affairs in April of 2011 in a much more extensive way, but at least it gives you an idea. So these were our key findings. The first thing we were looking for is, now that we knew what the problems were, we had the pharmacist in the doctor's office working with the patient, the family, and the healthcare professionals to improve or resolve the problems that we found. We wanted to look at what was the difference in quality. Now remember I said this was not a diabetes study or just for high blood pressure patients or whatever. So we had to look at what was our measure of quality improvement. What we decided to do is we made like a global or a bundle, and we said, let's just look at, for this patient, let's look at what their treatment goals were for their diseases. So if their treatment, if they were hypertensive, we had a blood pressure goal of 140/90 or whatever the evidence-based guideline we were following said. Or if it was diabetes patients, we said their goal, treatment goal, is hemoglobin A1C less than 7. So we took the standard guidelines for treatment goals and we said, okay, let's look at the first visit, which we call our index visit, the first visit with a pharmacist. At the first visit, what percentage of patients met their treatment goals? Meaning, if I have diabetes and hypertension and, let's say, a lipid disorder, which is very commonly the three that come together, I have 3 treatment goals. Okay, so I had 3 treatment goals. Somebody else might just have hypertension. They have 1 treatment goal. But let's look and say at the first visit with a pharmacist, the baseline visit, How many of them were at goal for any treatment goals? And the number was 63% at the first visit. Then we said, after 6 months of working with the pharmacist in this intense way in a team-based environment where the pharmacist is the new team member, we went up to about 91%. At the very last visit, we measured how many of them were on. So we had about a 28% or so increase in meeting treatment goals with the pharmacist intensive management on the team. That is very similar to other studies in the US, which says about 25% improvement in quality. We were able to look at 96% of the drug therapy problems we identified were resolved. They were resolved. Many times it was done with just educating the patient a little bit better. It didn't mean the doctor needed to do anything more, but the pharmacist had more time and could really work closely with that patient. 76% of the drug therapy problems were actually preventable medication errors that required us to intervene with the patient or with the prescriber. So I think that shows kind of what intense working with the pharmacist in a team-based environment can do for quality. When we looked at care gaps, this is something that probably is, to me, as the researcher, was the most exciting work that we could actually summarize from our study. We found that if you classified all those drug therapy problems, that 70 to 75% of them were what we call upstream. They're all due to clinician influence gaps in care. So things like prescribing practices, care coordination, care management, medication monitoring, all those clinical factors were related to 70 to 75% of the problems with appropriateness, effective dosing, and safety and adverse events. Those were all things that we as clinicians need to work on in a team and become more actively involved in. When in the US, what you hear on the TV, the radio, read in the newspaper, is that the biggest medication problem is patients not taking meds, lack of adherence problems, right? If you that's good if you're just looking from payer data or you're just looking at claims data. But when you're looking at the whole use spectrum, which is what we did, 70 to 75% of those problems can be improved by clinicians working together on a team, pharmacists being involved. Only 25 to 30% of the drug therapy problems in our study were what we call patient influence gaps, like they didn't believe, their health beliefs didn't make them want to take the meds, or they had problems understanding health literacy, or they were non-adherent. They just didn't take them. So that's a big finding, and one that's counter to what we hear in the press, let's say. We also looked at team-based care efficiency. How efficient was having pharmacists? Is it burdening the practice, or is it more efficient? And we found that a little over 3/4 of the drug therapy problems were actually resolved with the patient working with the pharmacist. Didn't require another visit to go back and say to the doctor, oh, by the way, this patient has a problem you've got to fix. We could actually fix it and work with the patient. And the last part of this was cost. So we looked at cost the 12 months before the patient was involved in the pharmacist interaction and 12 months after. And what we found is actually we saved money in get rid of drugs that were discontinued. Now, in the United States, you might understand this. In other countries, you might not necessarily have something to equate to. But here we have a lot of programs which are auto refill programs at the pharmacy, which means you're on a med, the pharmacist says to you, to not have to worry about reminding you when the next refill is done. We're going to automatically fill it for you, call you, or deliver it to your house. Now that sounds really good. The intent is good. But what if that med got discontinued or changed, the dosage changed 2 months after it was prescribed? All those meds are still getting delivered to the patient, or the patient's told to come pick them up, and it's totally confusing to the patient. Some of them actually take the meds thinking that, oh, the doctor and the pharmacist must have talked and I'm starting this med, or I didn't stop it. But we were able to get rid of a lot of that waste of discontinued meds, and that accounted for about $1,100 per year per patient. Then we looked at what about if we created and took care of some of those problems upstream at the point of prescribing, being right in the doctor's office, what could we do to medical or hospital or ED visits? And we actually were saving about $470 per patient per year. The return on investment, for every dollar that it cost to have the pharmacist involved, the return was roughly $2.5 to the system with regard to these savings. So that's actually pretty good in the United States. If you can get 2.5, some people have gotten in the United States have gotten up to around 10 or 12 in unique circumstances. But I would say somewhere between 2 to 4 or 5 is probably normal when you get a pharmacist involved in a team-based care for this much intensity. And this was very intense. First visit, like I said, probably about an hour. The second, third, all the other follow-up visits were at least 30 to 45 minutes. What do we think related to the success of the program? We talked about the pharmacist met with the patient in the office. That told the pharmacist, that told the patient that the pharmacist was part of this medical team. We had access to the EHR, which most pharmacists don't have, so we could look at labs, we could look at discharge summaries from the hospital, from the ED, we could look at encounter notes from the physician, consults from other physicians. We developed a profile of active meds that the patient uses at home. So we improved the medication list, the accuracy and completeness of the medication list in the chart for the physician. We built a trusting relationship with patients based on face-to-face visits. The reason I say that is because sometimes you have a lot of this being done because it's less expensive by phone. And you'll have pharmacists who are calling patients, have no relationship with them, they don't know who they are, they've never met them, and it might be cheaper to the organization or the payer or whoever is sponsoring it, but it's not as effective. And we actually matched the frequency and the duration of the visit to what the patient's need was around their complexity. So if we identified in the first visit 4 drug-related problems that we were working on, the second visit they came back in a month, 3 weeks, whatever, and we found that 2 of them were resolved, then we might let them go for 6 weeks. So they didn't have to come exactly, we kind of matched it to what their level of progress was at meeting their goals. And the other part of that, we think, was this integrated team-based care model. It really reestablished the relationship between the patient, the prescriber, and the pharmacist, which is almost lost today in the era of high technology and big box pharmacies where you get something filled, you don't even know who the pharmacist is. You may not even ever talk to them. A clerk might be the person you interact with. It really does establish this team-based environment. I told you that we had a high level of patient engagement. We had roughly, this is actually, I don't know how many of you have worked with Medicaid patients. They're a difficult group to get back and come back to your visits. We did incentivize them. We had to incentivize them. We felt to offset the cost of bus fare or something like that to get them back. So they were incentivized, but not in a big way. It was really $10 or something for round-trip bus fare and that kind of thing. It empowered patients. We gave them an action plan at each visit, and we gave them things to work on before the next visit so they could become engaged. We looked at all diseases, not one disease, so we felt it was very real world. And physicians accepted pharmacists as a trusted healthcare colleague. Actually, in fact, after the study ended, there was no more pharmacists there. And I have active, ongoing discussions 5 years later of how can we get the pharmacists back? How can we do this? So we're working on models that are not grant-funded. This was grant-funded. The last thing I'll just close with is you might say, well, what did the patients think of this? Or what did the providers think of this? So these are some quotes that we got from patients. The first one says, the most important part of meeting with my pharmacist was she communicated with my doctor, and then we were all on the same page. That couldn't say it any better, right? These programs also offer the patient the opportunity to ask questions that they're embarrassed to ask the doctor about. They weren't as intimidated talking to the pharmacist. And the last one was, I get answers to questions that I could not get from a busy pharmacist inside a store. And this is not to, in any way, downgrade or be critical of pharmacists in community pharmacies. I have a sister who practices in community pharmacy. They are so busy, they would love to talk to people, but they can't. And so a clerk often has to do it. And there's always an opportunity the clerk will say, do you want to talk to the pharmacist? But quite honestly, I think the patients feel, look, I see they're busy back there. I'm not going to interrupt them. They don't want to interrupt. So that's the patient experience. Providers, what did the providers think about this when this was new to them? They had not had a pharmacist in their office before this. So a little over 90% of them found it helpful to have pharmacists identify drug therapy problems. That's not something they were trained to do and had a focus on in their visit. 82% of them made a medication adjustment based on the pharmacist's recommendations for that summary note that went back to them. 100% found the primary care provider-pharmacist collaboration important to assure safe, appropriate, and cost-effective med use. And 90% wanted pharmacists these services, medication therapy management services, for eligible patients. So we thought we had a very good working relationship with those physicians, and it seemed to be positive for them as well. So I'm going to end here, and we have a little bit of time for questions, I think. Anybody have questions?
Yes, I would like to know who's paying for this.
So that's a good question. This was a grant from the federal government, Medicare and Medicaid, that was only available to the state Medicaid. You had to apply for it. So state Medicaid, state of Connecticut Medicaid, we worked with that Medicaid commissioner to put this grant in. And we were only small part of the grant. The grant was about $5 million, but we were only one part of it. We were probably about $800,000 of that. The rest of it was to work on their e-prescribing systems for Medicaid and health information exchanges, HIT, and that. So we were just one part of that. The question and the thing that breaks my heart is it's not sustainable, meaning it showed good results, but here's what happened. The commissioner who sponsored it at the time when we were working with him, a new governor came in, so we had an election. The governor appoints the commissioner for Medicaid, and that person we worked with was out. A new person came in, had no interest whatsoever in what we did not care if we published it, what the results were. His focus was on something totally different. So this program is not in effect. It didn't continue after the grant, which is the sad thing that happens, right? But we are trying, so I've actually gone back and worked with, there's a new office in our governor's office, a new office for healthcare innovation and reform, and I know the person who's in charge of that. That person was very supportive. He happened to be not the commissioner at the time, but a director in Medicaid, so he was aware of it. He didn't work with us, but he was very positive about it. Now he's the head of the Office of Healthcare Reform in the state, and so I've been working with him. We just got $45 million to come to the state of Connecticut to work on a total state innovation model, and this is built in there. So it's not happening yet, but we've got our fingers crossed. It's built in. But the issue of who pays for it going forward is a good question, because pharmacists can get paid only on the cost for dispensing drugs in the United States. They don't get paid for being team members and being clinician colleagues. So we're working on that. There's bills in Congress to see if we can change that. There are some insurers are experimenting with paying pharmacists for doing these things, but it's not pervasive. And so therein lies the fact that it's never been sustained. It's never been picked up, even though when it shows, and our work is very similar to others. We aren't the only ones who have showed this kind of results, but it's not picked up because there isn't a payment model right now. But we are actually, that's in fee-for-service or billing for your time and visits. But where I think the opportunities are going to come, and we've got a little bit of an example now of how it's changed already, is with new payment systems, with more value-based or risk-based contracting that's going on between private insurance companies, the federal government under these accountable care organizations, or value-based arrangements, the pharmacist is really creating a lot of value, and the payment now may not go from the payer to the pharmacist, but more than likely, I think it's going to go from an insurer to quality improvement and performance-based contracts to the physicians' offices or physician groups, and they're going to be the ones who pay the pharmacists to come help them achieve that and meet their targets to get bonuses or incentives and that sort of thing. So totally new payment model is actually going to be very positive for pharmacists, I think.
Okay. More question? Would be a bit...
I can't hear, so
No.
repeat, yeah.
Your project was with
Medicaid
Medicaid patients,
right.
Yeah. Do you expect to see, probably a similar profile with other patients?
Yes. So we have, I would say, I can talk about Connecticut, but I think we're typical of most of the rest of the country. We're seeing, because of the new payment models around care for the elderly, we're seeing Medicare. So federal government start paying differently to provider offices to keep elderly patients who have a lot of meds, a lot of chronic meds, right? They're just as complex as these patients we have, right? To keep them, prevent medication-related problems, keep them out of the ED, rehospitalize, keep them more in the community, working in team-based environments. So Medicare is starting to do that. And they are doing it through new ways. Again, the pharmacist isn't billing. The pharmacist is being hired part-time sometimes full-time, by the provider practices or the ACO. And then they are creating enough value to help that practice or that ACO meet their quality goals to get their performance payments. And that's where the payment stream is coming. So it's not coming directly to the pharmacist. It's the pharmacist being now integrated into that team. And that provider group or provider network or ACO is actually paying some of that money. And we're starting to also see it in the United States, once Medicare does something, the commercial payers will start to look at it too. And so we're starting to see that effect right now.
Okay.
Question over here, I thought.
Be more rapid in the answer.
He's okay. I can hear him. Yeah.
Just some observations of over here. I'm much more of the layman, but I am a user of the pills. Mm-hmm. And my use, as I age, like you say, increases.
Right.
And so where it says to take your medicine with food, I joke with my wife, I have enough in my hand.
It is food. Right. 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 Right.
And what's happening is inevitable, is trends with technology and momentum that have unintended consequences. And in the United States, it involves for us, because of our infrastructure, conversion and change. Mm-hmm. Other parts of the world that don't have the infrastructure will migrate to the change more quickly, because that's how TV likes to deliver. For example, if you've never had a landline system, your first phones are wireless.
Right.
In the United States, it's a big deal to go
That's right.
wireless, because we have all these lines in the air, and we have to change. So the observations are this. The pharmacies, the big ones, as the chains are getting more CVS and
Yep.
Walgreens dominant, have a model that the people are like airplane pilots and interchangeable. So you don't have a pharmacist.
That's right.
What
That's
you have
right.
is a person that day
That's right.
is a pharmacist.
A shift worker.
So
Yep.
the eye
Yep.
contact and intimacy
Yep.
that this envisions is being taken away through that business model.
I agree.
Two is at the same time, big programs like Express Scripts are taking the business away from the pharmacist, mail order,
Yes.
and there is no pharmacist.
Right.
At best, there's an 800 number
That's right.
that may be not in the United States, and you're trying to relate your situation, which discourages the interaction that you
That's right.
So you got two
That's
variables
right.
moving against
And they're big players.
at the same
Yeah.
time.
Yeah.
The complexity of the deal, if you get 4 drugs, all with a different name, but you find out they're actually the same
Same.
drug 95%. And someone says, well, I take this and this, and the doctor goes, they're the same thing. The ability of the consumer,
Right.
as I escalate from 1 to 2 to 10 pills, to have any ability to manage that, I lose.
That's right.
I can't handle
Yep.
the terminology, the complexity. As you
Yep.
know, the insert So it seems to me one of the things that may come is an evolution that when you have certain drugs in a cocktail, some pharmacy or a pharmaceutical company will say, I will give you one pill that now combines those, so that the patient doesn't have to remember that I take 10, like a multivitamin, I take one.
Right.
But we'll see what happens.
Yeah.
I just believe in
No, those are good points.
how hard it is.
Yeah, no, you've made some very, very valid points. And independent pharmacy is probably still where you see that relationship, more of a smaller town, rural areas. The other thing, though, in more urban areas is, at least in the eastern part of the states that I'm aware of, if you go to a grocery food chain and they have a pharmacy, they tend to look much more like an independent pharmacy. They're smaller, right? And so, and there are some pharmacists who really kind of, go against the corporate rules and still want to be a pharmacist. You'll find every now and then you'll find one. And that's good. If the person changes, you might find that doesn't happen anymore. But I always say, if you are at a point where you need to have a pharmacist or somebody in your family needs to have a pharmacist, keep looking around. There's one, but it may be harder for you to find them, But your food store, big food store pharmacies, even regionally, will usually have a pharmacy in them, and they tend to be not so labor intensive around having to fill a quota of scripts every day like the big box stores do, regardless of safety or anything else. They have quotas to meet. It's horrible. But thank you. Those are very good observations. Thank you.
Okay, more questions?
Am I getting the hook? Yeah. I'll be happy to answer any other questions you've got.
I think we have come to the end, and
Okay.
Maria,
Thank you.
Thank you very much for your speech. And I would be happy if there have been more people listening to what you had to say. Unfortunately, we cannot do anything about that now. But we will we'll give you a diploma for your presentation. So please